والصلاة والسلام بسم الله الرحمن الرحيم والحمد لله والصلاة والسلام على رسول الله. I would like to welcome our speakers and chairperson, and we are honored by their accepting our invitations. And also I would like to welcome all of you, our delegates and attendants, for our last webinars before the summer vacations. And after the summer, we have already prepared couples of webinars until November, when inshallah, until October actually, when inshallah we'll have our conference in peritoneal dialysis form, which will be a retain pack, as we are, all of you know that we have held it during the COVID pandemic. I will not take longer time, but please, your CME hours, you will earn it electronically once you attending today the meeting and you registered. And it is, as you know, it is for the target audience, specifically for the target audience. No need to write your name or your Saudi Council numbers in the chat or in QRE. Once you registered, we have it already, and it will be entered electronically to your account at the Saudi Council. I will not take further times. So Dr. Wafa Twajri, just introduce yourself, and the mic is yours, and introduce also the speaker. Dr. Wafa, the mic is yours. You are muted, Wafa. Wafa, you are muted.
Yeah. Yes. Thank you very much for the Saudi.
Oh, you have internet connection problem, Wafa, it looks like. Wafa, I think you have internet connection problem, Wafa.
University Hospital of Würzburg, Germany.
Wafa, we didn't hear you, unfortunately. I think you have internet problems. Maybe
can you hear me now?
Now we can hear you. Yeah, go ahead.
Oh, okay. I apologize for the interruption, and thank you for the Saudi Society for organizing this webinar and all the very informative webinars throughout the year. It gives me great pleasure to introduce our speaker for tonight, Professor Christopher Warner. He's a professor of medicine and chief of Division of Nephrology and Hypertension at the University Hospital of Würzburg, Germany. His areas of interest are metabolic disorders and cardiovascular outcomes in patients with diabetic kidney disease and other rare diseases. He served as the principal investigator of the 4D study and as steering committee member and the Central Europe coordinator of the SHARP study. He has published more than 500 PubMed reference scientific articles. He's an executive officer at the KDIGO and a co-chair of several guideline work groups and controversy conferences. He was the chair of the European Renal Registry from 2009 to 2015. Without further ado, allow me to present and pass the mic to our presenter for tonight, Professor Warner. The mic is yours.
Thank you very much. Very pleased to be invited by this prestigious society, and very pleased to have such a large audience tonight, which is following my lecture. So I'm going to my first introductory slide, which is the type 2 diabetic with kidney disease who is losing 16 years of lifespan. If he is young, then he will be losing 16 years. I saw in the past a male patient. He was 65 years old, and he had diabetic kidney disease. So he asked me, doctor, how is this going with me? And I couldn't tell him that he is losing 10 years or already lost, and he is close to the end of his life. But this is the problem for these patients. And today we can do something about. So here is my patient. He's 65 years, a male, and I found a kidney disease diagnosis, IgA nephropathy. He had a biopsy 8 years ago elsewhere, but he also had type 2 diabetes diagnosed 4 years ago. So look at his GFR, already decreased, and urinary albumin creatinine ratio was high. So maybe he had both, more IgA nephropathy or eventually type 2 diabetes. We cannot find it out, but anyway, we can treat his progression factors, and his blood pressure was not optimal, I would say. Look at his body mass index, LDL cholesterol, hemoglobin A1C. He is a non-smoker, very good. He struggles with lifestyle, he told me, and experienced recently dyspnea while walking stairs. And he told me, I take already 7 pills per day. So in the past, this profile was not so bad, but today with different targets, it is suboptimal. So look at his medication. He is on an ACE inhibitor, on a calcium channel blocker to control hypertension. And to control LDL cholesterol, he is on a statin. I do not know why he's taking aspirin. He has no cardiovascular disease so far. And he's on metformin and a DPP-4 inhibitor. So this is appropriate standard of care to the older style, but today we can do better. So I would try to explain this by first looking at guidelines. So this is a brand new, not yet published. You see on the right bottom, the published guidelines in 2020. But in 2 or 3 months, the 2022 update will be published. And what is the update saying? The update was already discussed at the ERA Congress in Paris a couple of weeks ago with presenting the new KDIGO guidelines. So on the bottom, you see a lifestyle, which we do all. Also, some patients struggle, but then you see a statin for atherosclerotic cardiovascular disease, a RAS blocker for preventing kidney disease progression, an Sglt2 inhibitor, an organ protective therapy for kidney and heart outcomes, and metformin for diabetes control. But we have shortly new medications on the market, which is a non-steroidal mineralocorticoid receptor antagonist called Pheneronone. And this was discussed by KDIGO, received a 2A grading. An A is very high evidence, and this is additional drug and heart and kidney protection for the short future when we get it on the market later this year. The GLP-1 receptor agonist I will talk about is a good anti-diabetic, but only lowers albuminuria so far. And additional risk factor control we all work on. So how can this be done? What are the missings and the questions for my patient? So what should I do? Should I increase the dose of medication? For example, ramipril 10 milligram, or should I switch to a more potent LDL cholesterol, atorvastatin, ezetimibe? I can add more pills, an Sglt2 inhibitor, GLP-1 receptor agonist, diuretic, calcium antagonist, non-steroidal MRA, Pheneronone in the future. Should I give him less pills, reduce metformin, use a polypill, stop DPP-4, it has no benefit for outcomes, and stop aspirin? So this are the questions out there, and I think many are appropriate. How to do, it takes a lot of time, and maybe it also takes more money in some countries on this world. So what are nephrologists doing in essence? Nephrologists look at the glomerular filtration rate on the left-hand side. It's 100% when the patient is young, for example, a type 1 diabetic. And when he's on the slope and a rapid progressor, he's losing 5 ml per minute per year. What we want from every doctor, GPs, that they help us to retard the progression of chronic kidney disease and push up the line to a better outcome. So our patient was first presented to me at a glomerular filtration rate of 40 to 50. So what can I do? I still can do something, but I have also to introduce a different time axis. He already was 65. And maybe I have to do more that he can reach 70, 75, or whatever. So this is our task. And this has recently been published in Nature Nephrology, Review Nephrology. Let's start from a diabetic kidney disease patient with albuminuria. He has an average GFR loss of 6 ml per minute per year. This would mean for our patient that he is on dialysis in about 5 to 7 years. And he is still too young. So we give him a good blood pressure control, which is first very important. And we have used RAS inhibition and have already changed the slope and pushed it up. We can now use an Sglt2 inhibitor and in the future, short future, also a non-steroidal MRA, Pheneronone, to push up this line when we work intensively with the patient, when he's accepting, when we can reduce pills, add something, and I will come back to this further. So this is the task of today. We have this medication in hand, and we can do something if the patient accepts our recommendation. So furthermore, we think that KDIGO is correct, left-hand side, the stages of glomerular filtration rate, but KDIGO also proposes measure albuminuria. And on top, you see the stages. And the more you move to the right with severely increased albuminuria, here the urinary albumin excretion rate, the more progressive is the kidney disease. And so we also want to reduce albuminuria to maintain glomerular filtration rate, because macroalbuminuric patients on the right-hand side or microalbuminuric in the middle at a certain stage are more rapid progressors. And you can remember your textbook from the student time. Here you have the traditional view, first derived from a type 1 diabetic, that you start with a GFR of 100 and then you hyperfilter at the beginning for a couple of years, and then you decline in kidney function. And the more urinary albumin excretion you have, the more rapid your GFR is inclining. This we know, and therefore we want to fight the nephrotic syndrome, the urinary albumin excretion rate. We only have to measure it. And this, not every doctor is following our advice in the moment. So now let's come to the data. What data do support such a strategy? And we can go back 20 years to the year 2001. And there was a significant effect published of an angiotensin receptor blocker renal. And the endpoint was a doubling of serum creatinine, end-stage kidney disease or death. And you can see that this beautiful drug reduced this endpoint, this hard endpoint, by 16%. And this was significant. And this is what we are doing since 20 years, blood pressure control and ACE and ARBs, and we have some success. However, there is still residual risk. So 20 years later, in the year 2019 or 18 years later, we saw data published with canagliflozin. thereafter with dapagliflozin. And these Sglt2 inhibitors, together with empagliflozin on the top, will retard progression of kidney disease, I will show you shortly. But we have published data from Pheneronone in large trials, which also have the potential. And in the year 2024, we may hopefully get also good data from the semaglutide, GLP-1 receptor agonist, and we hope that with the FLOW study, where the kidney is in the primary endpoint, we can further retard the progression of chronic kidney disease. So we have Sglt2 inhibitors, MRAs now, and maybe also GLP-1. So the entire data with Sglt2 inhibitors are here on this slide, the kidney outcome. On top, patients without diabetes, and in blue, patients with diabetes. And you can see that the Sglt2 inhibitor with dapagliflozin, empagliflozin in the heart failure trials and chronic kidney disease trials are effective. So you see the point estimates. All these point estimates are left of unity. They are very consistent, and irrespective of underlying heart failure or kidney disease or cardiovascular disease, you can influence the disease by about 40 to 50%, which is twice as much as you get with an ACE inhibitor. So this is our new surprise, and today we have the medication on the market for all patients with CKD. And this is also, left-hand side again, the same thing, also for heart failure. Heart failure in all these trials, hospitalization for heart failure or cardiovascular death, very consistent, and a kidney drug with an effect on the heart. I would summarize this. Then we had the Pheneronone trials, and this is one trial, which is Fidelio. And the Fidelio had kidney failure, which is dialysis, a sustained decline, 40% decrease in eGFR from baseline or renal deaths in the primary endpoint. You see on the bottom, the 5,600 patients in the trial, and the endpoint was significantly reduced by 18%. The confidence interval is quite narrow. Therefore, it's a robust result. The p-value is also nice. The number needed to treat after 3 years is 29, which is acceptable or quite positive. The time to cardiovascular death was a secondary endpoint with non-fatal MI on the right-hand side. And also these cardiac endpoints were reduced positively by 14%. The confidence interval remains below 1, therefore it's significant. Number needed to treat a bit higher. We also have Figaro, where the heart is in the primary endpoint, another trial with 7,000 patients, which is in the heart is in the primary endpoint, a positive result. So let's go further to the GLP-1 receptor. Thank you. In type 2 diabetes, the GLP-1 receptor agonists have the potential also to reduce kidney outcomes. You see all these trials with the names, 20, 30,000 patients here in these trials, and the endpoint worsening of kidney function, 40 or 57% decline in eGFR or dialysis, is positively influenced when you also include macroalbuminuria in the primary endpoint or in the secondary endpoint. It's all secondary endpoints. If you take macroalbuminuria out, then the point estimates move to the right and the result does not become significant anymore. Therefore, GLP-1 receptor agonists have the potential, but we want to see studies in the future where we can be sure that it also avoids heart outcomes. And this is the FLOW study we will get in 2024. But it looks good. So today, the management of chronic kidney disease in type 2 diabetes is in the moment ACE and ARBs, Sglt2 inhibition, and MRI Pheneronone, which will come in Germany to the market later this year. In some countries in the world, it is already available, and I think Saudi Arabia will also be this year available. So in most countries in Europe, this protection is available for €5 per day. I'm saying this because many countries which are lacking resources from the healthcare system, they complain that new medications are too expensive. But this is, for this benefit we get for our patient, may be acceptable. So why is Sglt2 inhibitor so good? We have now new data saying that there is a metabolic switch in the kidneys, which results in increased renal gluconeogenesis, which is a build-up of energy stores, of glycogen stores. The kidney is using less glucose and more short-chain free fatty acids and amino acids, so a shift in energy consumption. The kidney is going in more into a hypometabolism because the transporter is not reabsorbing such many glucose and has less energy demand, less ATP. When you have less energy demand, you produce less oxidative stress and phosphorylation. And this is an increase in cellular longevity for every cell. So maybe this is the mechanism behind. Hemodynamics are for us very important. It goes all along the hemodynamics, which is less single nephron hyperfiltration and intraglomerular pressure, because we modulate the vas afferents by giving an Sglt2 inhibitor. So what are the topics around the Sglt2 inhibitors, which are called the statin of the 21st century? It's a very small risk of diabetic ketoacidosis, but it's there, and therefore we cannot use it in type 1 diabetes. There is an increased risk of genital infection, and we use hygiene measures, and then it becomes less significant and maybe a very short small sign of urinary tract infection. We have questions about the very elderly, which have no thirst, they're incontinent, they are frail, but with the Sglt2 inhibitor, they have no hypoglycemia. We have a decline in eGFR in some at the beginning, and I think we have now data saying that this is a good sign, and we do not ask anymore, what does that mean? When you decline glomerular filtration rate, it means that the drug is working. The nephrologists say we have no data on polycystic kidney disease, lupus nephritis. What are we doing after transplantation? We may discuss this. The diabetologist is saying we have no recommendation for type 1 diabetes. What about bone fractures and amputation? And yes, we can use combination therapy. I would say there are limitations, but the standard of care and the Sglt2 inhibitors are good for 75% of all CKD patients. More pharmacologic interventions, summarized in a recent paper in eClinical Medicine, summarizing all trials, the net effect of sodium glucose co-transporter. Very good signal in all heart failure trials, in all type 2 diabetes at high atherosclerotic cardiovascular disease, in all trials with chronic kidney disease, all meta-analyzed. There is no acute kidney injury sign, so the decline in GFR is a positive sign. There are more mycotic genital infection. You look at the right, yes, this is acknowledged, and a few patients cannot be treated, but most are. We have a very small sign for urinary tract infection, you see a 7% in a very large group of patients. Look at the big numbers, and I think these are solid data. When we look at amputation, this is a mixed bag. In heart failure trials, in the more modern, no signal. In kidney trials, no signal. It all comes from the atherosclerotic cardiovascular disease risk trials with peripheral arterial atherosclerosis. Maybe there we have to take care. And there is no signal of bone fracture so far. And death from any cause is but beneficial, so the benefits overlie the negative effects. Then what about the future? The future is in after credence, after DAPA-CKD in EMPA-Kidney. You see that Credence has published data on diabetic kidney disease, DAPA-CKD on proteinuric CKD, with diabetes and non-diabetic kidney disease, and EMPA-Kidney had more non-diabetic kidney disease and non-albuminuric patients. Look at the number of patients, and the glomerular filtration rate varies. Over time, we go lower and lower, and all these trials have been stopped for overwhelming benefit. EMPA-Kidney has been stopped and will be published in November. So there must be a benefit from eGFR more than 20 to 45, and KDIGO guidelines already in their guidelines told us you can use Sglt2 inhibitors from eGFR 25. Don't stop until patients go into dialysis. So you can really use a wide range of GFR. And here in EMPA-Kidney, eGFR 20 to 45 without albuminuria has been included. Here are these trials again summarized. You see the eGFR of Credence, lower in DAPA-CKD of 43 ml, and with EMPA-Kidney 37 ml. UACR is lower in EMPA-Kidney because many patients without albuminuria have been included. On the left-hand side were the cardiovascular outcome trials, and not many patients in these cohorts had an eGFR below 60 or macroalbuminuria. This is in kidney-specific outcome trials totally different. Here's some data which have been now published in NDT, Nephrology Dialysis Transplantation, last month, from the EMPA-Kidney study. You see on top, on the left-hand side, the glomerular filtration rate ranges, and then on top, the amount of albuminuria these patients have in the various categories. And below 20 milligram per gram is no albuminuria, 20 to 200 is a form of microalbuminuria, UACR above 300 is macroalbuminuria, and there were many patients with above 500 and above 1,000. And you can see that 34%, so a third, have very low eGFR when they were included. And in every category, 1,000 patients, and this data will again contribute to the knowledge we have. The EMPA-Kidney comparison to DAPA-CKD, when you look at glomerular disease, there are 1,600 included. And in the DAPA-CKD group, there were 600 because the sample size is smaller. More hypertensive renovascular disease included, and mainly non-diabetic kidney disease. If you want to know what type of glomerular disease, then you could look at IgA nephropathy. And we have 812 in EMPA-Kidney and 270 in DAPA-CKD. So in a certain time, we can look at more than 1,000 patients with IgA nephropathy. And this is important. I think all for us nephrologists also, as well as here some with focal segmental glomerulosclerosis, membranous nephropathy, and a few with minimal change and other glomerular diseases. I just come back on the IgA nephropathy because many patients have been included in DAPA-CKD, the primary composite outcome. And the curve is here with a DAPA-CKD, 312 patients in the placebo group and 197 patients in the DAPA-CKD group, with a 39% relative risk reduction and the number needed to treat of 19. And within this group, there were secondary outcomes. Yeah. And you can look at the secondary outcomes of DAPA-CKD with diabetic nephropathy, the majority, but then ischemic hypertensive nephropathy and glomerulonephritis, and the point estimates are all left of unity. So this is promising. And if we look at glomerulonephritis in the subgroup of these patients, then we look at DAPA-CKD with 270 patients with IgA nephropathy. The testing study from China and the STOP-EGAN study, where we base today our treatment decisions, were smaller. And on the right-hand side, the primary outcome in participants with IgA nephropathy was reduced by 70%. I've never seen a medication 70% reduction. This is too good to be true, but there are not many outcomes and the number of people are small. So we are really looking forward to more data to EMPA-KIDNEY, where then we can look at thousands, 1,000 patients. If this is true, we have to rewrite the story of IgA nephropathy. Maybe the IgA nephropathy comes along with bouts, always flares over time. And when you give an Sglt2 inhibitor, you lower intraglomerular pressure, and then the flares are not so deleterious. In the moment, a trial is ongoing, the FIND-CKD trial with Pheneronone in non-diabetic kidney disease. And we will see in the future that also, and we expect that Pheneronone is also working on non-diabetic kidney disease patients, but this trial is ongoing. So how did my patient do? He did not come in 3 months. He had too much to do. He went to the eye clinic, to the foot clinic, he went to the cardiologist, and he had no time for me. But he had a very good general practitioner who followed all the recommendation. And I must say, this is my best patient. I was really surprised. His blood pressure was fine. His GFR dropped. I made this sign green because it is not a bad sign. It is okay if he is dropping the GFR, because we lowered the intraglomerular pressure and the filtration. His urinary albumin creatinine ratio was only 400 milligram per gram. He lost 8 kilograms, but I think it is not the Sglt2 inhibitor. So what happened that he had such a good profile? First of all, in Germany, we have a polypill. And this consists of an ACE inhibitor, 10 milligram, a calcium antagonist, 10 milligram, it's amlodipine, and atorvastatin. And therefore, it reduces the bill burden. He got a diuretic to lower the blood pressure. The metformin was reduced by the general practitioner because of fear to accumulate, and he got a GLP-1 receptor agonist. But these patients maybe lost the kilogram because he got a GLP-1 receptor agonist. I would give these patients tomorrow additionally on top Pheneronone, and he will still accept this. He's waiting because 1 polypill, 1 diuretic, 2 metformin, 4, and 1 SGLT2 is 5. He's so happy that he has 5 pills only per day. And he has accepts one more pill to reduce the residual risk to drive the UACR further down and avoid progression of chronic kidney disease. We can do a lot today, but the patient needs to accept and we need to have the money for this medication, but we can avoid dialysis. What is coming in the future? Here we saw a trial, SONAR, published 2 years ago with an endothelium receptor antagonist, atrasentan, in the Lancet in patients with type 2 diabetes. This trial was stopped because of low accumulation of endpoints. But when it was then unblinded, we saw a perfect sign of protection. And because the number of endpoints are not enough, then this study is further developed with more data, and we may get it to the market in about 2 to 3 years. But it is a perfect protection, a 35% relative risk reduction. The confidence interval is nice, but the proportion of participants who got this beneficial effect was relatively low, so we need more data. But maybe one time we can build up a temple with more medication, using also GLP-1 receptor agonists and endothelin receptor antagonists one day. Pharmaceutical companies are working, and Bayer, for example, is also working on 2 drugs, which is a soluble guanylase cyclase activator, and companies are working on aldosterone synthase inhibition. And they are all in phase 2, but by the year 2030, we may have them also in the armamentarium. And we have to work hard with our patient that he can get this medication and takes the medication if he's accepted and the resources are there. So future is relatively bright for nephrologists and retarding the progression of chronic kidney disease in type 2 diabetes and without diabetes. However, before we can prescribe these medications, this is always the same. We need to detect the disease, diagnose the disease, and detect the problem early. And maybe some other doctors come to help us nephrologists, and these are the cardiologists with their cardiovascular risk assessment. Cardiologists and the European Heart Journal, the European Society of Cardiology, they have accepted the KDIGO heat map on the left-hand side. And KDIGO has 4 risk classes. You know, in green, no CKD, in yellow, CKD slightly increased, in orange, CKD moderately increased with the risk, and CKD severely increased. And cardiologists in their guidelines simplify the language and say they have low CKD, moderate and severe CKD. And we have sufficient data to recommend in guidelines that you, with moderate CKD, you have high cardiovascular disease risk or very high. So if you can diagnose kidney disease by eGFR and albuminuria, you can stratify the patients according to his risk. And cardiologists propose to include into the risk assessment, cardiovascular risk assessment, also the diagnostic tools to diagnose kidney disease. And you know exactly what it is. So a patient who is reading guidelines does not exist. But you can transfer this in newspapers, and my patients read this. And he asked me, "Doctor, do you know my ABCDE?" And I told him, yes, I know this exactly, and we can do something about it. And he is happy. He has the numbers now. He is following, compliant, Not everybody is doing this. Maybe we have to simplify the message. Take this, and this pill may be patient-centered, focused, personalized medicine. If he is not tolerating a RAS blocker, just give them a non-steroidal mineral or corticoreceptor antagonist. If he develops high potassium, we add an Sglt2 inhibitors or a bit more diuretic. There are multiple approaches. I have tried to show this with my patients. Lot of things to do, but successful work at the end. And I thank you for the attention.
Thank you, Professor Warner, for the very thorough and comprehensive talk. We open the room for questions for the audience. Any question for? We have few questions here, but let's see if there is any more questions from the audience as well. Professor Al-Huwais is asking if there is any experience of using Sglt2 receptor antagonists in end-stage renal disease patients, particularly peritoneal dialysis patients who have good residual urine output.
We have only a very small study with 50 patients in peritoneal dialysis patients. And this is only a safety, but cannot be efficacy. Yeah. We have no data. When you think pleiotropic effects, you could use it in dialysis patients or hemodialysis, but the trial data are waiting, and there is a trial designed with 2,000 dialysis transplants patients, which will start in the short future, and we get the answer in randomized controlled trials so far. For example, in EMPA-KIDNEY, we do not stop the Sglt2 inhibitor once the patient is to go into dialysis, but we do not know whether this is beneficial. Thank you.
Okay, thank you. Another question is whether there is a role for Sglt2 inhibitors in transplant patients.
What I can say from meta-analysis and published data, yes, it works. For example, 135 patients in a meta-analysis were published recently. So they have a dip, they decline in glomerular filtration rate. Glucose excretion is blocked. So the transporter is blocked, glucose excretion is increased. They have a bit more osmotic diuresis. So the control of blood sugar is limited because normally they have lower kidney function. But apparently it works. We hope that we get data one day. Every transplant center is now trying these drugs. It has a handful of patients. The infection rate is not higher apparently so far. So yes, it can be used, but there is no wide recommendation out there. Thank you.
Okay, thank you very much. Another question is about what are your expectations with hyperkalemia with the use of Pheneronone and how to deal with it?
So we have these 13,000 patients in hands, and the risk was visible, but it was not, let's say, a big problem. There was no death, and the potassium increased from 4.4 to 4.6 on average. There were 1.7% of more hyperkalemia episodes. So 17 patients of 1,000 treated. The risk is there. However, it's not a big problem. And apparently, when you combine it with an Sglt2 inhibitor, the risk is completely neutral. So it may be a relatively ideal combination. to avoid any hyperkalemic side effects. Yeah.
Okay, thank you. There is a question that's been repeated by many of the participants: is what about ACE inhibitors compared to ARB? Which one is superior in the management of CKD?
I think they are both equal. We have the renal and the IDNT studies. So we mainly use the angiotensin receptor blocker. Losartan and irbesartan was tested. However, interestingly, with all the other trials, telmisartan and candesartan in the heart failure and antihypertensive medication, many centers switch to candesartan or telmisartan, or what is available in your country. And there are data out there that very high doses of ARBs are very good, nicely tolerated, and have a higher antiproteinuric effect, higher than what has seen in the big trials, in the cardiovascular Sglt2 inhibitor outcome trials, because in an individual you can use higher doses of ARBs, and this should be tested or used in the future. Yes.
Okay, there are a few questions from the audience that were already covered in the lecture. There's a few questions that might not be specifically related to our talk. One question that just came up is, what alternative medication do you use to treat albumin urea in patients who do not tolerate both ACE and ARB?
If they do not tolerate RAS blockers, currently all these patients should be on an ACE inhibitor, on Sglt2 inhibitor. Yeah. Okay. All. And if they make sure that the blood pressure is down, because blood pressure also helps, and most patients are really not very well controlled, and 130/80 or even lower when they have albuminuria should really be controlled, sometimes by 24-hour blood pressure measurement. Yeah. Then salt is still a factor, low salt diets. And in the short future, in 2 or 3 months, these can all go on Pheneronone, the mineralocorticoid receptor antagonist. We do not use steroidal MRAs. It potentially, they lower albuminuria, and we use it very rarely when the compliance of the patient is good. Yeah? But 50% get hyperkalemia, and therefore we are really reluctant, but it is still a possibility. Thank you.
Okay, thank you. A question is about diabetes treatment. Would metformin still play a major role, or do you think Sglt2 inhibitors will just replace the role of metformin?
You see, the metformin has no very good evidence-based database. And the cardiologists live in the world of evidence, and they say, why are you using this old drug? I would say, and KDIGO said that with metformin, we have 30 years of experience. And it is such a cheap drug, and in many countries of the world, we need to have cheap drugs on the market. Experience is large, you can control glucose, and therefore you should still use it. However, some other people say, why using this huge pill burden? 2 more pills per day. So I understand those doctors who say, I replace it completely. Currently, we say, combine it. Yeah? So this depends, is an individual decision of a doctor talking to a patient. Yes.
There is a question, I think you already covered this on the slide, Professor. is the role of Sglt2 inhibitors in specific glomerulonephritis like in FSGS. I think you had a slide on the role in non-diabetic kidney disease.
Yeah, for dapagliflozin, the label and approval is out there, so you can use it. There are some forms of FSGS which may not respond with this disease tremendously, but in chronic forms, it may be a good treatment to reduce albuminuria.
I think those are the major questions. So unless there is any more questions from our audience, allow me to pass the mic to Dr. Khalid Al-Hassan.
Thank you very much. May I get in? First of all, this is Ahmed Mitwali. I'm really sorry I had a technical problem. I had to join a little bit late. Thank you, Dr. Warner, and thank you, Dr. Wafa, for good moderation. I'm really sorry again, but I thank everybody, and I want to remind everybody what the Saudi Society of Nephrology are doing. We are trying to improve quality of spreading knowledge, especially on nephrology. By the way, next week we have another webinar, and we hope everybody will join. We are happy that this webinar, we had almost over 1,000 participants join this webinar tonight. Thank you for Dr. Warner, and thank you for Dr. Wafa. And I thank you all for being with us. And thank you to Bayer Company for supporting this activity. And they are always with us. And we thank them for their support for the society and for spreading this knowledge throughout Saudi Arabia and the rest of the Arab world. Thank you again.
Thank you.
Thank you very much. Good night.